The surgical procedure I am going to discuss today is a posterior spinal fusion. I am going to present some background information first on scoliosis, since this is the main reason a child would undergo a spinal fusion. Scoliosis, by definition, is a lateral curvature of the spine. Curvature must be greater than 10 degrees in the frontal plane with a vertebral component that's seen upon X-rays. Scoliosis may occur during infancy, childhood, or adolescence, and females are 10 times more likely than males to require surgical correction. Types of scoliosis. There is infantile, which occurs between the ages of 0 to 3 and is congenital in nature. Juvenile, which occurs between 4 and 10 years of age. Idiopathic, which represents 80% of all scoliosis cases and typically occurs during adolescence between 10 to 16 years of age. There is a genetic component with this type of scoliosis. Neuromuscular scoliosis is caused by the Cobb method. This is the method that orthopedic physicians use to measure the degree of curvature. Radiographs are needed and done serially in order to demonstrate or monitor progression of curvature. The most tilted vertebral body above and below the apex of the spinal curve is used to create intersecting lines that give the curve an objective measurement. As you can see, this is a nice diagram that shows the Cobb angle. You can see the apex, and then the vertebra that's most tilted above and below that apex forms those intersecting lines, which gives the degree of curvature. So, preoperative management often includes bracing. Bracing is often indicated to prevent further progression of curvatures. They are used in both neuromuscular and idiopathic scoliosis, and bracing can benefit these patients because it may help improve their sitting posture and their trunk stability. Very often with curves that are over 45 degrees, bracing is often not helpful. So I'm going to review preoperative management and continue with that. There is evidence that exercise may play a role in decreasing the progression of curvatures in adolescent idiopathic scoliosis. This was an article done by Negrini et al. Exercises that are beneficial include core strengthening, spinal stabilization, flexibility, respiratory and postural awareness, and alignment correction. Physical therapy prior to surgery may be beneficial as there are many restrictions in mobility postoperatively. And you will see this in a demonstration that's done at the end of this slideshow. Also, just as a side note, a home exercise program may be beneficial prior to surgery as these precautions are quite limiting for an extended period of time. Spinal surgery. This surgery involves placing bone anchors, which are screws, hooks, and wires, into the vertebra, then rods are placed next to them and attached to the anchors. The most common approach is posterior. Other options are anterior, which puts the lungs at risk for atelectasis and pneumonia, or a combination of anterior and posterior. With a posterior approach, the surgeon will expose the spine from the back and then place the instrumentation in the spine and slowly correct the deformity. Intraoperative x-rays are utilized throughout the surgery to assess the spinal correction. Once adequate correction and balance is achieved, bone grafts, which are taken from the ribs or hips from the patient, or an allograft or donated bone is placed along each vertebra to encourage bone healing. This takes about 3 to 4 months to stabilize and about 1 year to fully heal. Potential complications. Intraoperative monitoring of the nerves are continually done to avoid neurological damage to the peripheral nerves or spinal cord. Blood loss is a risk, and during many of the surgeries performed today, a cell saver is utilized. The cell saver collects the blood loss from the patient, removes the tissues, and then is available if a transfusion is required. Pseudoarthrosis, which is where there isn't enough bone healing, can be a risk factor if the fusion fails to heal, and this risk increases with heavier adolescents and smokers. And as the patient ages over time, there's a risk for disc degeneration, which can be related to decreased flexibility and decreased range of motion, which puts greater stress on the low back. Surgical types. Harrington procedure is a more dated procedure. It was developed in the 1960s, and it corrected the spinal curvature, but it did not account for the continued rotation that could occur, and so a full body cast is needed postoperatively. Flat back syndrome, where the patient may lose their normal lordosis, can also occur. The more commonly seen procedure is called the Cottrell-Dubosset procedure. This corrects the curve and also the rotation component and does not cause flat back syndrome as it does in the Harrington. Additionally, with this procedure, bracing is often not indicated or not needed unless it's a more involved patient or a patient who has neuromuscular scoliosis and a high degree of curvature. So in the video that you're going to see next, you're going to view a clip of what a typical session might look like with the patient post-op day 1 from a posterior spinal fusion.